So good morning, everyone. Thanks very much for coming. And we are very privileged and feel very honored to share what we're doing in our Project 3.3 Be Can Solve theme. And our project is to increase the number of living kidney donor transplants in Canada. And so many of you will identify with this lady who's in the dialysis unit. And certainly whenever health professionals are involved in her care, we can't be so impressed with her because she comes every day in center to the hemodialysis unit 3 times a week. And despite everything she's going through, every time you round on her, she's always talking about the issues that other people are having in her family, how she's doing to help them, and she never really focuses on herself. Now, you know that she would benefit from a kidney transplant, and unfortunately in your area where you live, just like many places in Canada, she'd have to wait 4 years or more to get a deceased donor kidney transplant. And so really we're trying to think about how can we help her receive a living kidney donor transplant? And that is our team's common goal. We heard yesterday in talking about forming teams, what are we focusing on? We're focusing on this very simple, very important issue. And why do we feel this way? Well, we know if she receives a living kidney donor transplant, compared to the alternative of dialysis, she'll live longer. Of course, it depends on a patient characteristics, but most patients will live 10 years or more, have 10 years or more life duration if they receive a transplant versus remaining on dialysis. She will certainly feel better, have a better quality of life. She will reduce costs to the healthcare system. Of course, in the first year of transplant, it's a bit more expensive than dialysis, but generally, every 100 kidney transplants saves the Canadian healthcare system $20 million over a 5-year period. In addition, think about the cost of disability and social assistance. For those on the webinar, we have Lawrence Geller and Braden Mans in the room along with others who are involved in a project that looked at the disability and social assistance costs to people with kidney failure when they cannot work. And imagine if you are able to get her to a point where she can go back to work. This is substantial money to the Canadian environment. And compared to a deceased donor kidney transplant, she doesn't have to wait for the time for her to receive the transplant. And as you know, sometimes people on the waiting list get ill so that they can no longer get a transplant. We avoid all that. And even if on time zero, even right up today, if she can get a living versus a deceased donor transplant, her survival and the duration while that kidney will last will be longer with a living donor transplant. On average, a kidney will last from a deceased donor from 12 to 15 years and from a living donor 15 to 18 years. So this is why our team, this is why many people, even in this room, want to increase the number of living kidney donor transplants in Canada. But in reality, the number of living kidney donor transplants in Canada is stagnated. It's sitting at around 500 living donor transplants a year. And despite an increasing waiting list, that number has not changed. And so we really need to make an improvement. And the reality is, unfortunately, the current reality in Canada is that many people would benefit from a living kidney donor transplant will not receive one. That is the reality. And unfortunately, why did this occur? There are certainly barriers at many levels. We can think about that in 4 groups here. So first of all, the person with kidney failure. Some people in this room, unfortunately, are living with kidney failure. There are issues around knowledge. What is the knowledge around transplant that they have? Can that be improved? What supports do they have in pursuing an option like living donation? This is a very daunting thing. Ken, who you're going to hear from, is talking about getting a kidney is not like asking someone to help you move on the weekend. It's something very, very different. So what supports do we have to support people struggling and living with kidney failure to consider living donation? What are the logistical issues? What is the communication that we're having between frontline staff? Was the communication always consistent? Are we giving always the same information at the same time, multiple times through a patient's journey with their condition? I would put forward there's many areas that we need to improve here. For families, in truth, many families are not aware or don't have good knowledge about what a living kidney donor transplant would do for their loved one. Many times it's hard for someone with kidney failure even to bring these issues up with their family. So if there's communication issues, there are logistic issues on donors as they become donor candidates, that we're going to hear about in a moment. And of course, there's the costs. Especially imagine if my spouse, my wife has kidney failure. I'm working. I have to go. Who's looking after the kids? I'm getting evaluated. Around the time of surgery, who's going to be helping us with things? So for some people, costs are a major issue. And if you look at healthcare providers, it even gets a little bit more complicated because many people trust their primary care physician, but primary care physicians often don't have a full knowledge of this area. Then there's the renal healthcare professionals, and then there's the transplant centers. And I can tell you firsthand, there's sometimes a bit of a disconnect between renal health professionals and transplant centers, how they're communicating, how they're working together, so that it's a very patient-centered experience and it's seamless, which doesn't currently occur. Many people who are working in the field will say that they don't have the time and resources to do this properly. Some people actually have said that they don't have the knowledge. This requires a fair amount of coordination, and is there even accountability in the system? And then finally, in healthcare systems, it's also involved because we have provincially based funded healthcare. Certainly a lot of this activity occurs in the province, but now we also have national things. You may have heard about this opportunity of kidney pair donation, where if you're not compatible, you can start donating through kidney swaps, but that's a national program, so that requires coordination with the provincial programs. Again, there's issues of funding, coordination, accountability. And so just one of these things, again, to give it more, to bring it to life, some people call this the big ask. How do you even make the big ask if you're someone with kidney failure to your family members and friends that you need a kidney, and how can we enable that? So our project team, who you'll hear you'll hear from some of the members during our presentation, and hopefully everyone will come up at the end, are really dedicated and committed to trying to improve this. We have 4 patient co-leads. We have 16 patient donor and partners. We have at least 13 researchers. We have 3 policymakers, partners, and several more. And of course, we have a major health charity who's supporting us in all this. And so we heard yesterday, it's nice to discuss our journey and our stories in patient-oriented research. And someone gave the nice example of, we're all in the canoe. How do we make sure the canoe is moving well in the right direction? So this is our journey from summer 2015 to summer 2016, before we fully launched officially in CanSolve. So there were also other metaphors about our senses yesterday, and certainly we have, we're given, the saying is we're given one mouth but 2 ears for a reason. And so to start off, we had 7 one-hour teleconference calls with patients and their partners, and you'll hear from some of them today, where we just listened. We listened to what the issues were, what people were considering, and that helped form our prioritization of what we wanted to tackle in theme 3.3b. It is an investment. Of course, everyone's busy, but you have to invest that time and take the time really just to listen. And there was no cell phone use, there was no emails, it was just listening and learning what people are coming from. So then that featured in some of the projects that we're developing. As you know, the CanSolve leadership organized a stakeholders consensus group meeting in Toronto in the summer of 2015, and people had to rank what they felt was important, and we were very pleased that we were on the right track because we got tied for the #1 rank. While we were waiting for CanSolve funding announcement, we felt it was very important to have a patient-led, donor and recipient-led workshop in Toronto to, again, further define what we wanted to do. Because we didn't have full funding, this was predominantly Ontario-centric because we had some limited resources to do that. And then we're very, very appreciative to hear that CanSolve was funded in early 2016. And then we had a large team meeting here in May to confirm that our priorities were correct, that our scope and projects were on point. And just to let you know about that patient-led initiative we had, this occurred in March 10th, 2016 on World Kidney Day. There were 18 patients, many of them are in the room. And really the focus was donor and recipient identified barriers and solutions to these issues. And so we have our projects organized in 2 themes. Theme 1 is to improve the evaluation process for living kidney donor candidates. And you'll hear why that's one of our main themes. And we're using a national approach there. And theme 2 is to test the solution to help more patients with kidney failure receive a transplant, kidney transplant. And that's an Ontario-based approach, but certainly with national sharing. And with that, I'm going to invite Dr. Stephen Habus, who's currently a PhD student, very prominent PhD student, funded by the CIHR with a doctoral award, who's been involved in all the CanSolve meetings to date, to speak about this first part, improve the evaluation process for living donor candidates. Thank you.
Okay, so this slide is going to have a lot of information on it, but it's not intended for you to actually read it. I meant slides you can read. So this is the living kidney donor candidate evaluation process. This is a process map of how living donor candidates are worked up at London Health Sciences Centre in Ontario. So this is this is just the first phase. So in the blue on the top, that's the initial assessment. Just like the previous figure you saw, someone jumping through hoops. That's sort of what this may feel like, test after test after test, which can take quite a long time. And it goes on. So this can take quite a bit of time, which for some people can be far too long, could be agonizing. And we could probably make this a little bit more streamlined and more efficient. But we need to understand where we can do that, how we can do that, and whether or not we should do it at some points, yes, some points maybe not. So approximately 3 out of 4 living donor candidates who come forward, they don't actually ultimately become a living donor. And that could be for many reasons. Sometimes you have multiple donor candidates come forward for the same recipient. Other times, maybe donation is not right for that person. So there are many reasons that we have to consider. So one question we would ask is, well, how long does a living donor evaluation actually take? And we have some living donors in the room who can attest to this, that it can take quite a long time. So we have some data that we were able to look at. And the reason why we looked at some of this data is because of those conversations that we've had with donors during all those conversations we've had over the last 2 years. So we said, well, we have some data at our disposal. What can we do with it? So the data that I'm going to show you here was taken from 900 prior living kidney donors across Canada and 1 center in Australia. So what this graph shows, on the y-axis you have the time in months. And this is showing the time from when the donor started the evaluation until they actually donated. So this is only those who actually donated. And on the x-axis, we have different centers. So we have, in this graph, 13 different transplant centers across Canada and 1 across Australia. And we're de-identifying the center just to avoid saying one center is better than another. So this graph shows 2 key time points. So one thing is that the evaluation process takes too long, or it takes a really long time. On average, so the median, you see the horizontal bars, and the solid horizontal bar that goes all the way across is 11 months. Now that's the average time from start to finish. The second thing that this graph shows is that there's a lot of variability across transplant programs. Some centers have times on average between, say, 6 and 7 months, other times on average closer to maybe 14 months. So there's quite a bit of variability that we don't quite understand, but we need to. So going forward, it would be great to have process maps drawn for every program so we can actually compare and try to find the best solution. So this is just some quotes from a prior donor candidate that we've had. They feel like their life is on hold. If they thought it would take this long, they would never have signed up for this. This was a direct quote. Using some other data that was available in Ontario, we estimated, so for one of those conversations, actually Sue brought up the question saying, well, how many times does, when a living donor candidate comes forward, is the recipient who is not on dialysis ends up on dialysis before the donor can finish their evaluation? And that's something we definitely need to avoid. If we can avoid it, we should, because preemptive transplants are, I would say, the gold standard for living donor transplantation. And as a result, we looked at some data, and we estimated about 1/3 of recipients actually start dialysis when maybe they didn't have to. So that's something that we definitely need to improve. And improving the evaluation length by even 10% can really impact healthcare cost savings. So for example, every month on dialysis, it's a lot of money. So even small reductions in the evaluation time can have substantial effects, especially when we expand it to across Ontario, across all of Canada. So there has to be a better way to do this. And in our research, we will try to figure out what those ways are. So now I'm going to introduce Ken. So Ken is our co-lead on this, and what ended up happening is that when he joined, I kind of dumped on him like 3 or 4 different stacks of papers that he had to read, and he'll let you know his experience with that.
Good morning, everybody. I'm Ken Litchfield, and my experience as a co-lead on this program offers a lot of learnings for people in other projects. One of the things that I have to be mindful as a co-lead is that you still have chronic kidney disease as a patient partner and a co-lead of the project. And early into joining 3B as a co-lead, I became very sick and spent 10 weeks in the hospital. So that set your project team behind. So one of the things that we identified by necessity is that we had to bring on an additional co-patient lead, because there's a lot of work to do, especially working with Stephen when you get all these binders of of paper. I almost thought I got a secondary diagnosis when they started telling me that I had to review a Delphi. I didn't know what a Delphi was. But ultimately, I've had kidney disease for 3.5, well, actually it's much longer than that, it's 8 years, but I've been in end-stage renal failure for 3 years now. And I'm looking at this from the inside out. I've got a lot of skin in the game. I have a lot of passion for living donation because I'm a person who is desperately trying to seek a living donation. So it's self-motivating completely. And when we met originally, when I became involved with CanSolve last May at the CanSolve meeting, one of the things that became apparent to me as a necessity was to get diversity in your patient program. So one of the things I'm very proud of with our co-patient leads is we have many different perspectives in the 3.3 group. Myself, I am ultimately seeking a transplant. We have people who have had very successful transplants and are living very, very successfully. We've got a brand new colleague who has had some challenges post-transplant and is back onto dialysis. And most importantly, we've got the additional perspective. We have a donor as a co-lead as well. So we're building some real good understanding and offering a lot of perspective in the work that we're doing. So my co-leads, we have Roger Hillier is a brand new co-lead, and Marianne, breath of fresh air. Marianne is our donor co-lead, and Sue and Leah, all of these folks working very, very hard to give perspective to the research teams, to all of the people that are involved in the 3.3B project. Now, this was my secondary diagnosis. When I was told I had to review this Delphi, my Lord, I have worked in projects most of my adult life. Before I left on medical leave with kidney disease, I was a project guy, but I'm an executor, and I don't mean that with a knife. It's I am a get it done person. So I'm in construction, and I looked at this as kind of like the front end of my project. And really what this is we had this data available to us, right? We had this pool of data. We talked about those 7 one-hour phone calls. We had all of this information from patients, and we needed to remove a bit of perspective and let's put some science behind this. So by doing a Delphi study, we were able to take a systematic approach using an online and paper-based study, and we're going to build the combined wisdom of more than 300 people from across the nation of Canada. And it's really to gain a better understanding as to why the evaluation is taking so long. I want to offer a little perspective on that. For a lot of people, you look at a year as an important period of time in your life. For somebody who's got failing chronic kidney disease, a year at the end of their life is like a lifetime, right? A lot of stuff happens in a year. How should we measure the actual time frame? You know, are we consistently measuring what we need to measure? What is the impact of an inefficient system? Well, standing before you as a donor, I can tell you what the impact is. When we look at the participants of who we are going to survey in our national survey, we have, of course, patients providing us a very, very valuable perspective. We have healthcare providers and healthcare administrators. And really, the patients are informing the design at our meeting today. So today we're going to be reviewing a number of the Delphi questions. We're waiting with bated breath to get out there and start capturing this data so we can get her done, so we can start executing some things. And but what we want is the feedback of patients involved to assure that we're on the right track and measuring the right things. And this is where I love this slide, because I get the ability to flip the switch from inefficiency to efficiency. So our next steps on theme 1, that's the project that I'm the co-lead, is complete the Delphi. So once today we'll refine and get a final stamp of approval on the Delphi. That's going to allow us to gather this critical scientific data from patients and administrators and healthcare providers, and then we're going to be able to analyze the data. We'll give it to the data guys, and the data guys will begin to process this and understand the current patterns that exist that are outside of the straight perspective. We're going to focus primarily in theme 1 on the modifiable factors. There's no sense focusing on the constraints that we can't address. We need to focus on what can be addressed. And the modifiable factors is where we're really going on the next step of theme 1. And we're going to begin to develop standards nationally, looking for opportunities where we can put together the best of the best, the mean average, and gain a real national standard. And from that, we hope to develop and test solutions to improve living kidney donor evaluation. And it's critically important for a large group of people in this room. And now, I'm going to introduce Amit again. You all know Amit. Thank you kindly.
Thank you very much, Ken. And so now going on to the second theme we have 2 themes, is to test the solution to help patients with kidney failure receive its kidney transplant. And this is an Ontario-based project, but we're using the learnings to inform what's being done in other provinces as well. So just to orientate you to Ontario, Ontario has 13 million citizens, 20,000 have advanced chronic kidney disease approaching end-stage renal disease therapies. There's 11,000 patients on dialysis right now. There's about 1,100 patients on the kidney transplant a deceased transplant waiting list. And there's about 220 living kidney donor transplants done a year, which is about 17 per million population. So we have the leadership of the Ontario Renal Network here in the room, Ms. Rebecca Harvey, and Trillium Gift of Life Network are 2 organizations that help organize and manage and provide provincial leadership for renal and transplant services in the province. And these organizations work with 26 chronic kidney disease programs. I'm from the London Health Sciences Centre. That's one of the 26 chronic kidney disease programs. And there are 6 transplant centers in 6 of those programs. So London Health Sciences Centre is one of the chronic kidney disease programs, and we also have a transplant center. And then the other programs that don't have a transplant program refer to a program that does. So that's how it's organized in a healthcare delivery model to care for these 30,000 some patients who could be considered for transplant. And really, we've set a provincial goal where we want to increase the annual rate of living kidney donor transplants by at least 20% by 2021. And so we have developed a strategy on how we're going to do that. And this strategy has been developed over the last 2 years in a very much a patient and healthcare administrator framework, participatory framework, including through a priority panel that includes representation from multiple different stakeholders. And we know that just one solution or one component of the solution will not work. We have to do a number of things together in order to move the needle in this space. So our multi-component strategy has several things about it. It has data audit and feedback. So right now, the transplant data isn't really talking to the renal data. And so we're trying to combine those through a data sharing agreement, which we've done successfully in one way. And now by the combined data, now we can show CKD programs exactly how you're doing. And we can present that information in ways that they're more likely to act on it. So that's the data reports part and data component of it. The educational resources. We need educational resources and toolkits for frontline renal health professionals. We did a needs assessment, and they said they clearly have some gaps they would like addressed so they can really truly be providing best information to the patients in front of them about the option of kidney transplantation. There's education we need to give people with approaching kidney failure or on dialysis. We need education to provide their family members and friends. And so that's also another key part of the strategy. Sometimes you just also need additional resources and money. And so there also is financial administration and provincial organization that's being used in the strategy. And finally, when we've done, again, a needs assessment with patients in the Ontario setting, and this is true for Canada, certainly many patients value the advice that they get from health professionals. But they equally value the advice they get from people who've gone through the process and have the same lived experience. And in fact, in some randomized controlled trials, when you've had whatever we would call as peer support, that's helped people go through more steps of the process and be better satisfied with the process. And in one setting, it even increased transplants in another country. So we see that being incredibly important, and you're going to hear shortly about the Transplant Ambassador program that's been developed. That's a major key part of our strategy. And so just to set the stage, also this is a research framework. So we want to prove or disprove that this package of activities does have an impact, that they do move the needle. So as I mentioned, there's 26 chronic kidney disease programs that care for about 30,000 patients. And we've developed this Access Kidney Transplantation, or ACT trial. What we've done essentially is that we randomly allocated those 26 CKD programs into two groups. One, usual care, which is things as usual. And the other one, the other group is going to get the multi-component strategy. We've already now done this, and we've given the information to the programs who we're going to be working with. And then this goes live in September of this year. And then over the next 2 years, we'll be able to compare the two groups and determine whether one group compared to the other groups has a difference in the transplant referral rate, the number of people evaluated for living kidney donation, and ultimately the number of transplants that are done. That's really what we want to see, an impact. There were a number of logistics we had to work out to get to this point. One, we had to, again, work out how we're managing all the data. We're using existing data sources, both in Ontario and multiple different organizations, and combined it so that all the information we have already we're leveraging towards the purpose of this trial. We also have to work through a number of ethical issues because you certainly can't go to 30,000 patients and get consent to suddenly now roll out this strategy, and so we had to work those issues, and we got approval in the province to do this. Just one methodologic point, particularly for the science people in the room. There's no magic about randomization. So you heard yesterday in one of our Cancel talks about randomized controlled trials, and those are often considered the best form of evidence to give us knowledge about whether something works or doesn't work. But when we have something like this setting where we have 26 chronic kidney disease programs and we need to put 13 in one group, 13 in the other group, and then follow forward, if you randomly put them in two groups one time, flip a coin, by chance alone, there might be a difference between those 13 and 13. Like if you do 10,000 and 10,000, then everything gets very similar. But when you just do 13 and 13, you can get a chance that there's an imbalance on key characteristics. So then when you look at the results and follow-up, is it really true to our strategy, or is it because there was just some difference between them at baseline that's just carrying over in the follow-up? So the way we resolve this is kind of a new methodology where we did the randomization through a simulation exercise 1,000 times on the existing information we have, because we already have all this information for the last several years, and found those schemes that gave us the best balance on over 100 measured characteristics. And then when we had 10 of those, then we randomly chose one. Methodologically, that's called covariate constrained randomization. But the principle here is that that is allowing us to give a nice sense that at least on everything we can measure, these two groups are identical, so that if we see a difference in groups in follow-up, we can hopefully attribute it more confidently to what we've been doing. And also, finally, we did not want to deny anyone this strategy. So everyone is going to be getting it. It's just the order. So after 2 years, people in the usual care group will then get the strategy as well. Now, as a part of CANSOL CKD, I think we are all learning and growing in patient-oriented research. And in our projects, we've thought about many ways how we can truly and meaningfully partner with patients. So one, you can do the prioritization. What should we be studying? Two is you can look at the design. How are we going to do it? Three is, okay, we're doing it. We're getting it done. How can we get help now getting it done? When we get the results, can we get help or not help? Can we all work together to interpret the results? And then when we have the results, can we broadcast it out in ways that it's most useful to the scientific audience? So those are, we've been trying to make sure we do all those things. But now let's take this to the next level. Not just should patients be involved in all those things, can they actually be involved in delivering a solution that we're testing in a research setting? And can they be involved also in reviewing how we're using our resources and reviewing our budget and making sure that we're doing the right things, using it in the most effective way? And so those are two things we've really done also in our project. We think we're really proud and excited about that. And with that, I'd really like to bring forward and invite Ms. Susan McKenzie to the podium here, who's been really instrumental in leading this whole initiative right from the very beginning, including the very first call we had now over 2 years ago.
Thanks, Amit. It has been it's been a journey, 2 years. I can't believe it. But it's been great to be involved in, since the first slide, which was what, May 2015, when we started those first 7 phone calls, and we had no idea where this was going to go and what was going to happen. And I think for patients who have, more recently joined CANSOL, that's probably what you're thinking now. We thought that for a long time, but I mean, coming out 2 years following, I mean, we can really begin to see where our efforts have made a difference and how we've been heard, and how many of the things that, some comments that we made in those meetings where maybe you think, you make a comment like, well, why does somebody have to go on dialysis when they have 3 people, ready to go forward, and yet they end up on dialysis? And then you find out that they've pulled the data and they're investigating this and trying to figure it out. And I mean, that's I think what CANSOL is really all about at its essence, because you know that you're not the only one going through that there's so many more going through it. So I think for us who have the health at this time in our life, or this moment in our life, or this week in our life, where we feel that we can make a difference, it's such a great opportunity. So I think for those patients who haven't felt that yet, stick with us, you're going to feel it soon. So I don't know, I want to at this point talk a little bit about the so I guess before I do that, I think we're all in the sharing circle, many of us, but for those of us who didn't make it, I'm also a transplant recipient. So I had a transplant 7 years ago after being a crash start and having 6 donors come forward for me. I was still on dialysis for a year, and that's fine. I was only on dialysis for a year, so I'm blessed for that. And I'm blessed that my donor, Marion, my sister-in-law, is here today, and I've got her involved in CANSOL after freshly retiring from a teaching career. Now this is her 2nd career. She doesn't know that yet, but she seems to have found many more things to do just in this last 2 days. You know, I think I lost my train of thought. But anyway, what we started to do out of some of those workshops, out of some of those early calls, and then we had a patient workshop in May where we gathered together about 30 patients to kind of review what we'd come up with in the 7 phone calls, say, you know, how does this resonate with a group of patients? And one of the things that really resonated with everyone unanimously was the idea that there was not patients available to talk to patients. There was not donors available to talk to donors, and that they did have. This is not to replace the healthcare voice. It's not to replace the doctor voice or the clinical voice, but it is an additional support that is desperately needed. And everyone who had that was very thankful for it. Everyone who didn't really felt that was a big gap in the system. And I had the fortune, the blessing to have a mentor who was an older lady, not that much older, maybe 20 years older than me, but that I was connected to through our church. And I mean, it made a huge difference to me to just have coffee with her, for her to tell me about her experience. And I think beyond that, just that she was healthy sitting there, she got through it, that there was somebody who got through it, that gave you hope that you could also get through this thing. So it was an important thing, and now we see it coming to fruition. So I want to introduce my co-lead. She calls us our partners in crime, Leah Getchell, who you guys know because she's such a great facilitator, but she is also a patient partner. She's seen this firsthand as a child of kidney disease, as she says, and that's certainly a perspective that has really also added a lot to the design and development of this program. So Leah, come on up and join me. We'll talk about this program. And I think, you know, as Ken made the point that I couldn't do this myself. I mean, we've done a lot of work with Leah. You know, Leah and I bounce off each other. Ken is now, you know, bouncing off Roger. Marion will soon be involved in her second career. And I think, you know, our message is we need to partner up to make this happen. And not just because we're patients, but because we're volunteers. Because we work and have lives, families, and try to do things, you know, once in a while that aren't kidney related, you know. Okay, so Leah's going to walk you next one, through the vision and the mission of TAP.
So to give you some context, so the Transplant Ambassadors Program is one of those 4 strategies, part of the multi-component strategy. So we're going to be having a Transplant Ambassadors Program roll out in September at 13 Ontario renal programs. So through lots of collaboration work, Sue and I and input from other patient donors have said that the vision of the Transplant Ambassador Program is that all patients living with chronic kidney disease and their family members are knowledgeable about and have equal access to kidney transplantation and living kidney donation in Ontario and beyond. And our mission, is to support patients living with chronic kidney disease and their family members in learning more about kidney transplantation and living kidney donation through a supportive, in-person, donor and recipient-based Transplant Ambassador Program.
Today? Yeah, you go ahead.
Okay. So, like Emmett mentioned, all of the 26 programs in Ontario were randomized. 13 were identified to participate in receiving the strategy. So now what we're currently doing is recruiting transplant ambassador leads for each of those programs. So those are going to be either kidney donors or kidney recipients who are going to take a leadership role in running the TAP program at their center. And we've created little job descriptions for what we want that transplant ambassador to do and what also the ambassadors themselves are going to do. We had a first orientation workshop with many of those participants in March in Toronto. We're going to have a train the trainer in June. So all of the ambassador leads from the 13 centers are going to come together. We're going to give them some basic training in how to run a mentorship program. So issues around confidentiality, not providing medical advice, how to handle difficult situations. So some of those is some mentorship 101 tools. And we've already started to design some communication tools. So we've got a logo, and it gives give and gain. So give a kidney, gain a kidney. That's sort of our tagline or whatever. So these vests are the vests that the ambassadors are going to wear. So they'll be identifiable. And how the program's going to run out is they will be wearing these vests. They're just going to be sitting in waiting rooms with their other patients, so that a conversation can be struck. Hey, what's this green vest about? Oh, it's because I'm a living kidney donor, Tell me more about that. There's a connection made. Oh, you received a kidney transplant? Look how good you're doing. Let's talk about that. Here's my experience. So it's really providing an opportunity to have really authentic connections that are not only to be so meaningful for the people, for the patients and family members, but an opportunity to give back and to share the positive experience that they've had with living kidney donor donation and transplantation. So we've developed a program guide, a program budget. We're moving. We're all we're going to get it rolling in September.
Yeah, and every time we move to one of these steps, they are like, so who's doing this? Oh yeah, that's us. Yeah. Okay, well we'll and we get it done. And with lots of help, we've been recruiting. We keep recruiting more and more help. But it's been, I think, a really rewarding experience to see it come together. There's a lot more work to be done, and we're going to be. We have to still develop our training manual. That could take a couple of months. Run that by a few partners, and then we have our next training session in June, right, with the rest of the leads. And I think we still have to run the materials by all of our peer canvassers and get their input and everything. Marion's already given us a change to our vest. So she wants the donor kidney to have a dotted line, cut out line around it. Yeah. So we thought that would be good. And anyway, so it's a full collaboration, but also I think what we know is, it's going to be difficult for patients and donors, and that's part of the training, to be going into these centers. And any of you who've been in them know that there's not usually a lot of conversation in those clinics. I don't know if maybe I was not in the right clinic, but there wasn't a lot of conversation happening. And whenever you did see somebody healthy, it was quite interesting. And you wondered why they were there. Must be in the wrong place. And I remember seeing somebody coming into clinic when I was sick, and this person was dressed up and had heels on and everything. I'm like, man, she's in the wrong place. There's no way this woman belongs here. And it turned out that, it's just post-transplant and everything. But I think that seeing that, it's just seeing it, even if you don't have a conversation, is a lot of hope. And I think even if you're not the kind of person who wants to engage, if there's somebody in the clinic, we all know it's like pulling that sheet over when a doctor's talking to somebody in the bed beside you and you hear everything, like, don't bother with the sheet, like you hear everything anyway. So it's like, it's like if someone's having a conversation behind you or across from you, everyone, how many people hear it? 10 people hear it. So I think even the people that aren't directly having that conversation will hear it and benefit from it, and that's a lot of what we think is going to happen with TAP. We also know that some of these conversations will be happening. They may make a connection in clinic, but they may meet later for coffee. There's also, we need to incorporate the home chemo patients, and that's going to be a really important piece of this as well. So we have to work out all those details, home peritoneal and hemo.
So lots of upcoming opportunities for continuing patient involvement, support, and guidance in 3.3B. So we're looking at this afternoon to really have our patient partners help refine, participate, and promote the Delphi study. Again, we want around 100 patients from across the country, so we're going to need everyone's help to recruit folks to do that. They're going to help us analyze and interpret the results. We want you to act as and recruit transplant ambassadors in all of the 26 Ontario centers over the next 2 years. Share our study progress, impact, and results in quarterly patient check-ins. and an annual face-to-face meeting. So those patient partners that we have that aren't in Ontario are still going to be closely connected to what's going on with the TAP, so that they can then go and be champions for this kind of program in their home provinces. So really, to bring it to a close, it's all bringing us back to that common goal, and that common goal that we all have is to help this wonderful woman and all those people in our lives, those people in this room, receive a living kidney donor transplantation, and that's what we're looking towards. So I'd like to just finish off by identifying who our patient partners are, and I'm going to ask you to all come up to the front, and we'll do a group photo before everyone disperses. So the 4 patient co-leads are myself and Susan, and then we have Ken and Roger and Marion now, so 5.
As of yesterday.
Last night, so, you know, around the glass of wine. It's great for student age. So come on up. And then to the 16 patients, I wonder if I have all my names. Oh.
Is there a way that I can see the notes?
So, I know, so, yeah, Lauren and Kate and Claire or and Chantal, Kevin, Mary. So if you know us, Han, come on up.
Oh,
Kevin, yes. Helen. Researchers in the room, Stephen and Amit.
And Rebecca.
Rebecca, we'd like to invite you up as our policy partner.
Anybody else who wants to join?
Taking a picture.
Fran.
Okay, perfect.
Well, we don't have help.
That's all right. Yeah, I'll peek over your shoulder.
Okay, we have to get close. Oh, here.
We're close enough.
Sure. You're good. You're good. All right.
Okay, everybody.
Claire, you're short. Yeah, what's your tush on the paper?
As long as there's no toast.
Are you good?
We're great.
Thank you.
Thank you.
You're done.
Limbo.
Thanks, everyone.
So maybe we'll do a time check right now. I think are we over time?
Okay. We maybe have time for 1 or 2 questions from the audience, and maybe we'll first get moving to the next meeting. So we'll just take questions locally here. Rebecca.
The biggest question at our table, we were talking about knowledge transfer last night, and can you explain how you see the funding works for your operating?
Sorry, can you just repeat that?
Money work with respect to implementation going forward?
Right. So the question, just to repeat, is in terms of the implementation for the second project, for the second theme project, correct? Yeah. So the second theme project where we're running out these multi-component strategies, how would the funding work? In truth, this is where partnership is so incredibly important. So all of the delivery outside of the TAP program, the patient-led program, is predominantly funded through existing structures. So the data piece is already funded through existing structures. All the provincial organization is organized through the Ontario Renal Network and also through Trillium Gift of Life Network. And really, most of the CanSolve resources are being used to evaluate. But if we prove it works, then we're hopeful that those organizations will see the value in it and continue funding them. But this is really a question for the organizations and prove that this is valuable. And right now in the delivery, most of the resources from CanSolve are used in the evaluation, not in terms of the delivery of the program per se, other than this very unique and very exciting Transplant Ambassadors program. And a little bit of the education too we've organized.
Clarify for me, how are you going to go about including the ambassadors?
Do you want to speak?
So we have already recruited leads in all of the 13 centers, and we're working with them to recruit additional leads or additional transplant ambassadors. But we've also met with all of the QI teams at a conference in March, at the end of March, right? March, I think it was March, and they already have lots of great suggestions for ambassadors that are already involved in their PFACs. There's only one that doesn't have a PFAC, I think, of the 13. We also have kind of that other workshop, that other group of patients that have come together that we can use as a resource that we connect with through emails and things like that. And then, of course, there's other agencies that we can. Did I miss somebody, Leah?
The ORN.
The ORN, yeah. Yeah, they also have a group of patients. And it was presented, I think the TAP program was presented at the ORN PFAC not that long ago. We had several people call after that who wanted to get involved. So word is spreading, and I think there's quite a bit of excitement. So we're quite confident that we're finding the people that we need. But we may also use this group and find more. It's another resource. We need donors and recipients. Yes, we need, but we have already a couple of donor leads in as well. So Marion's leading Mackenzie Health, which is, yeah, she just can't get away from Mackenzie.
And just because some acronyms are used, I just want to make sure everyone was understanding what was being said. QI, this whole framework is a quality improvement framework, and there are principles around quality improvement that actually we've adopted. And there actually is a program called Ideas that's run through Toronto on training people on quality improvement methods, and so we actually have got organized into that. And when we say PFAC, many renal programs have patient and family advisory councils, and so that's what that term refers to.
So that was wonderful. Thank you, Ahmed and team.